Hello and welcome to another session of the recorded virtual Global Spine Conference. Today's talk will be from Dr. Michelle Welborn from the Shriners Hospital for Children in Portland, Oregon, and will be on syndromic scoliosis. Enjoy.
I realize that the vast majority of you do not do pediatric orthopedics. And so I'm going to do a little bit more didactics for you just because I'm going to attempt to woo you to my arena. I think it's an awesome area to practice in. I get to do a lot with kids and I get to impact them for their whole lives. So I specialize in early onset scoliosis, which is going to be scoliosis before age 10. I only do spine surgery out here, and I also run the spine side of our skeletal dysplasia clinic. So that includes our patients with achondroplasia, arthrogryposis, osteogenesis imperfecta, and a number of other disorders. So these patients tend to face some unique challenges. Here's a patient that presented to our skeletal dysplasia clinic when he was 2 years old. He has Bruch syndrome. So for those of you that are not familiar with Bruch syndrome, this is about the worst thing you can imagine in that it's a combination of arthrogryposis, so fixed flexion contractures, and osteogenesis imperfecta, so brittle bone disease. So you have contractures and brittle bones. So it's a pretty challenging and extremely rare disorder. He's non-ambulatory. He's got multiple joint contractures and multiple fragility fractures. That was him at age 2. When he initially presented, he was given just a soft brace, just a supportive brace. And they followed him, and at age 5, they referred him to me. So the challenges with these kids is that you cannot treat metabolic bone disease patients with a brace. And the reason is that the disorder that impacts their spine also impacts the ribs and all of the bones in their body. And so when these patients get pulmonary dysfunction, it's actually typically because of rib deformity. And so hard braces like a TLSO will cause rib deformity and only accelerate the loss of pulmonary function. So we'll routinely give them a soft brace to support and help minimize the discomfort associated with their compression fractures, but that's about all you can do from a conservative standpoint. Additionally, you can consider optimizing the bone health. Now, this family is challenging, so we tried to get him on bisphosphonates for years, and at that point, they were still not on bisphosphonates. He's also non-ambulatory, which is also going to further degrade his bone quality because it's not weight-bearing. And he has a recurrent left tibia fracture, which I know spine surgeons everywhere are freaking out. It's not, the appendicular spine is not your territory, but being cognizant of what our overall bone quality I think is important. And, you can see here that recurrent stress fracture that he has basically anytime he tries to bear weight. So now up until the age of 5, he'd been slowly progressing in the coronal plane, maybe about 5 to 10 degrees a year, and the sagittal plane had held steady. Unfortunately, I didn't see him for a year, and when he comes back, he's had a significant progression of this curve. And so anybody out there who does peds might notice that significant kyphosis, and that this is a big concern for our patients with any kind of growing construct or just any kind of surgical fusion. I think all my co-hosts do adults, so I probably won't ask you too many questions. But is anybody else concerned about these changes? Yeah, no.
Yeah, hi, Michelle. This is Ali. Can you hear me?
Yeah, I can.
Yeah,
I can see him over time.
Yeah, that's all right. Actually, I'll try to chime in a little bit. We see quite a bit of syndromic scoli cases, and so we're getting our hands on these a little bit. Can you tell us a little bit about any MRI findings, any intraspinal issues, or any cord issues?
Yeah, so we'll touch base on that here in just a second. But the biggest thing for him is going to be that he's got some significant compression fractures. It's going to alter that vertebral morphology quite a bit. And then that's really going to contribute to the progression of the curve. And so in these kids, we know that if you have 6 biconcave vertebrae, that is going to be predictive of progression of your curvature in the coronal plane. And then also, if you have biconcave vertebrae at the apex of your kyphosis, that's going to be predictive of progression of that kyphosis. And so I like doing this kind of slide because I think you can see the changes over time. If you hide the pictures of the people, you'll see that most recent kyphosis and the lateral and just how much that's progressed. And so, you know, here our big concerns are going to be just that overall poor bone quality. And you have to think about, if you're going to do any construct posteriorly, your vector of pull is going to be vertical, but the spine's going to want to go forward, right? So if I'm pulling this direction with a construct, but the spine wants to go this way, you're really at risk of PJK, anchor failure, etc. And so I was less concerned about my sagittal deformity and way more concerned about I was less concerned about my coronal plane deformity and way more concerned about my sagittal plane. Coy, I know back in the day you used to do a little bit of peds. Are you still doing peds or not anymore? It's dead to you?
Not anymore.
Not anymore. You're very happy now, I see. So, you know, I think our biggest concerns for this kiddo are going to be that really poor quality bone, and anything, Wendy, that you're seeing in terms of that cascade over time, and some of those changes in that, you know, the bone quality. I mean, you can, you know, you're on mute, Wendy. Still muted.
Are you asking me a question, or were you just telling me something?
More,
this
I
is
think.
Too hard for me.
Okay, got it. Yeah.
Teach me about this, please.
Sure.
I don't do any peds, so this stuff I learned for boards, but I don't see this in real life.
Okay, so we'll do less dialogue and more didactic. Got it. So I think, you know, the big thing here is going to be, as everybody can see, when the poop is more radiodense than the bones, that's a bad sign. You never want to see that. I think the other thing that you can see here is that he is barrel chested, so that's actually a good thing. So being barrel chested is going to increase your A to P diameter of your chest. That does have some degree of preservation for lung function, but that is only to a certain extent. So as the diaphragm, you can see here, the diaphragm is still rounded, and that's good, but as that kyphosis progressed, then you will lose that rounded nature, and when it becomes very flat, it actually, that barrel chest will impede pulmonary function. So right now what you see is you've lost your lumbar lordosis, you've got a significant thoracolumbar kyphosis, there's quite a positive sagittal balance here. And so in terms of our preoperative evaluation,
can I chime in, Michelle? I was just going to ask something real quick, and I apologize if you were going to get to it. But do you know, based on the syndrome, that you know, that the spine may be rigid, or do you think that there's some flexibility in there?
Awesome question. So both. In that, in general, with osteogenesis imperfecta and with Bruch syndrome, the deformity tends to be pretty rigid because it tends to be more due to changes in the vertebral morphology. And so, especially as that progresses, it tends to get worse. That said, anytime you have a collagen mutation, that also affects your ligaments. And so you have to be really cautious in these patients in that they may also have some degree of ligamentous laxity. And so there is both more rigid, but then also the potential for flexibility maybe where you don't want it. So it's a whole pit of vipers.
Dr. Welborn, one quick question just before to kind of some of the surgical discussion, but We had one question from the audience about stem cells, and I would sort of add any other non-surgical therapies for Bruch syndrome, since I think a lot of the neurosurgeons are not familiar with it. You know, the one disease that comes to mind obviously is spinal muscle atrophy, and I know there's a new gene therapy that's available, but anything non-surgical that is available for this challenging condition?
So unfortunately, for this particular disorder, no. And so really what you're going to want to do is do more supportive care, optimize bone health. And we'll talk about that a little bit later, but vitamin D for people with more mild disease. So your osteogenesis type 1, imperfecta type 1, really the current vogue is to do high dose vitamin D for those kids to optimize what they've got. And then for those kids that have more involved disorders, you might want to consider bisphosphonates, which have pluses and minuses associated with them. Some of the things that we use in adults to inhibit osteoclastogenesis are contraindicated in kids because of the concern for potential tumors and then also for affecting growth. So we don't use some of those other things. There is treatment for SMA in the form of Spinraza, and there's some new forms that are even going to kind of target DNA and RNA synthesis and potentially kind of turn back the clock in a permanent fashion versus Spinraza, which does have to be given in multiple doses throughout the patient's life. There is some stuff that's being done in the world of achondroplasia, where there is a new medication that's in clinical trials that's helping to normalize height, but it is not impacting some of the spine disorders that we see with achondroplasia. So it's not changing necessarily for Raymond Magnum stenosis. It's not necessarily changing pedicle morphology, which is what contributes to the spinal stenosis. So there are some exciting areas of medications that are changing, but so far not for Bruch syndrome and so far not for OI. So we're looking at optimization right now.
Can I ask a question really fast before you go on about
Yeah.
Spinraza? Just that I do know. So
Right.
Because I inject that, because we do that, but we don't do it often because of the cost. Because we always have jokes because the vial is like $100,000 if somebody drops it, they're in a lot of trouble.
Yes.
So is that something that you're working on something else? People are working on something else so they don't have to be getting these injections. I didn't know they were lifelong. I thought you just had to give a series of 3 to 5.
No. So Spinraza you want to keep giving. There are a number of medications out there that are in trials that are more promising than Spinraza. So for people, to clarify, we actually have a muscular dystrophy center, and I'm actually not the provider for that. So my partner, Dr. Boughton, is awesome. So if you want to talk on SMA, I'd totally get him. So there are a number of different, very exciting areas of development in that. And Spinraza currently is most efficacious when you're younger, because what it does is it prevents the furthering of the disease, and as opposed to gaining milestones. So you'll stop losing milestones, but you won't gain them. Currently, it's indicated for SMA1, which in the past was fatal in infancy and early childhood. But we have patients that have been receiving Spinraza from the neonatal period, like very, very early on injections because of having had a family member that was identified with SMA. So they were able to identify them earlier, start the injections earlier. And some of those patients are actually walking. And this was uniformly fatal before. And now I'm not suggesting that they're out there running a marathon, but I'm saying that they're taking some steps. And so it is a big deal. The quality of life is dramatically improved, but it's super expensive. So
that's interesting. Thank you.
Of course, they are talking about making some reservoirs for that so that you can actually get intrathecal Spinraza, but because it is so prohibitively expensive and they're not sure if it's heat stable, they are still working on the clinical trials for that as well.
Interesting. Okay.
Or no, you went off mute, so I was just checking. So in terms of additional imaging, right now, if we go back to this guy here, you can see he's got significant sagittal plane abnormalities. We can see some pretty significant coronal plane abnormalities. And I think anytime we want to do a preoperative workup on somebody like that, there's a number of different imaging modalities we want to add. So all of these kids, I'm going to start with an MRI because I want to make sure that there's no intrathecal abnormalities. In general, they don't tend to have them, but if they do, I want to know about them beforehand. It also helps me give a general idea about their bone morphology. And I don't employ a lot of CT scans in kids just because of the potential for cancer. Sometimes they'll need multiple CT scans throughout their life. So I generally start with an MRI, and if it gives me enough information, then I'll go there. I was told that it was going to be time prohibitive to go back and forth to my MRI, so I'll just give you a couple representative slides. I also like to get flexibility films. So we know that how much flexibility there is in these curves is going to be predictive of the kind of correction we get. And so I want to see how flexible that curve is. And I know I'm a little concerned about his pelvis. So you can see here, this is where he is for his PA. And then on his bending films, there's not a lot of correction. So as Ali had suggested, these are pretty rigid curves. And that's, again, really due to the fact that in these disorders, the curves are due to the bone changes rather than ligamentous changes. The pelvis, this is a big deal. So for those of you who don't do peds, this is what we refer to as acetabular protrusio. There are very, very few disorders that will cause it this badly, but you do commonly see it in things like Marfan's, but this is about as extreme as it gets. So you can see here, this is his femoral head and this is his acetabulum, and they're basically touching. This is bad news if you want to do pelvic fixation. So you can imagine that if you're going to try to do an iliac bolt, or if you're going to try to do some sort of S2 fixation, that is going to be super, super challenging. Here are some of his MRI slides, and you can see, again, the compression fractures that are occurring through the apex. You can see that the actual canal is really quite capacious. And one of the things that we commonly see in some of these patients is actually that there's kind of an inversion of the ratio of the width to the height of the vertebrae, where they actually become taller rather than wider, which is the more typical pattern. And then on the far right, you can see one of the representative shots of his pelvis. And again, just how thin those iliac crests are. And so again, going to be super challenging to get pelvic fixation. So now, as far as our pre-op considerations.
Michelle, can I ask you a quick question?
Yeah, rock on.
I'm sorry to chime in, but you've raised some excellent points. And I think one of the points that would be helpful to both orthopedists, neurosurgeons, adult and pediatrics, is this question that comes up a lot in some of these talks, and you mentioned this, you get an MRI to rule out say an intraspinal anomaly, whether it's a thecal sac or a split cord or a tumor, which is obviously less likely. Correct me if I'm wrong, but the classic teaching is if you have an intraspinal anomaly, you may want to address that first before correcting the deformity. Can you tell us what's the latest and greatest when it comes to that? So if you incidentally find a split cord malformation, for example, in these syndromic scolies, what's your thought on that?
Yeah, so great question. And the literature is all over the board. So in general, if it's a split cord and it's bony, most people would recommend a resection. If it is not bony, there's literature that supports addressing it beforehand and literature that supports not addressing it. That said, if it's my patient, I'm absolutely having that addressed beforehand. In terms of other abnormalities, tethered cords, Chiari's, again, there's literature that would support not doing it beforehand. That said, I had a patient that I did who they had myelomeningocele. They had a pretty significantly tethered cord. As we know, all of these patients, even if they get detethered, will retether. Their neurosurgeon had said, no problem, go ahead with their surgery. I did a big correction, and she had some motor in her left or in her lower extremities before surgery. And on the concave side, she lost motor function. So she actually got weak on the concave side, not on the convex side, because the convex side got shorter, but I lengthened the concave side, further tethering her. And so I actually had to go back, take out some of the correction, and she got that back. So even though there's literature that says don't detether these patients, in my hands, I'm always going to have that done.
Great, great. No, thank you for highlighting that. I think that's really important. Would you agree with me, and I promise this is the last point, would you agree with me that, however, in some cases where your goal is not necessarily a significant correction, but rather a stabilization, in that case, you may get away without needing to treat an asymptomatic intraspinal anomaly if you're just stabilizing with very modest correction?
I think that's absolutely right. So I think that if you are going to just fuse in situ, that's a very, very reasonable thing, because there's certainly risks with taking down any kind of intraspinal pathology. And if it's asymptomatic and it's not progressive, I think that's really reasonable. And that's probably where those articles are gaining their support, because they weren't doing big corrections. But, you know, again, I think if you're going to try to affect any kind of major changes, I would probably recommend addressing that beforehand. And then the other thing is that thinking about your timing, you don't want those adhesions to get too stiff. You don't want anything to retether. So I typically try to plan my surgery within about 6 weeks of the neurosurgical procedure, provided that there's no complications. And by the way, please keep asking questions, because I think the dialogue is great. So going back to this kid, you know, in an ideal world, you get your hands on these kids a long time before you actually do anything surgically. You build trust because they've got a high rate of complications. You build bone because there are ways to optimize things. And in this kid, once we finally met, we were able to build that rapport. I was able to convince them to do bisphosphonates, and actually that really improved his quality of life. Bisphosphonates may not, so there's no evidence that says bisphosphonates will slow the progression of his curve, but those kids have a lot less pain. And so they tend to be more active, they tend to feel better. So I think it's a great way to build rapport with these families. So knowing this kid, he's got bad bone, he's on bisphosphonates, which may impede healing. He's got recurrent fractures. And I think that since these are adult folks on this conversation, you're probably not familiar with the Scoliosis classification, but this is our classification we use for early onset scoliosis. It is correlated with complications as well. And based on his curve type, he is a syndromic 3+, and they actually didn't have any 4+ in their article, but this was correlated with the highest rate of complications. So I'm pretty much screwed in every way. So if we think about what kind of fusion or what kind of construct we want to do, a fusion, so he's 6, he's following the growth curve, so he's got a lot of growth remaining. He's not going to be a short kid. So I don't think a fusion's the right answer as your first line. Maybe if he fails a growing construct, you can do that, but I probably wouldn't start with a fusion. Schilla and Lukey trolley are great techniques for guided growth, but not in this patient. So Jean Ouellet is the leader in the modern Lukey trolley literature. He is a phenomenal surgeon. He also does a ton of OI, and he doesn't do it in these kids. For Schilla and Lukey trolley, you need a very flexible curve, and that's not this. You also need to exert a fair amount of force on the bone. So really we're down to magnetic growing rods, vectors, or traditional growing rods. Since his ribs are affected by the same pathology, I think any rib fixation should only augment what you have and should not be your primary source of fixation. And I think in my hands, I would go with a magnetic growing rod just because he's skinny, he's cachectic. I don't want to do a lot of incisions on this kid. In terms of your level selection, so, you know, he's got a proximal thoracic curve. The apex is around T5. I want to go at least a couple levels above that and really take into account that sagittal plane. You really want to get up above that curve and really making sure that you've got good control. Also, that cervical lordosis is going to be a risk factor for PJK. And so just making sure that you've really contouring your rod and you're getting up high enough to prevent that. I don't want to go into the cervical spine in the beginning on this kid, but I do want to go high. So for me, I went up to T3. Distally, you know, when you try to decide about going to the pelvis in these kids, the way I do it is I have them sit with their hands in the air. If they can sit with their hands in the air, it tells me they have good trunk control and I don't need to go to the pelvis. This kid's non-ambulatory. You can see from his head position, his head is never straight. He doesn't even have head control. So he is not a candidate to not go to the pelvis. And also based on where his thoracolumbar kyphosis is, I think going to the pelvis is the only way to kind of restore that sagittal profile. So I'm going to the pelvis, but I remember how bad that pelvis looked. So it's definitely not a good thing. So preoperatively, we've already put him on vitamin D. I've got him on bisphosphonates. So as far as that's concerned, I'm going to stop those 3 months before surgery and restart them 3 months afterwards to optimize bone healing. I'm going to put this kid in halo gravity traction to try to effect some degree of correction before surgery because I can't push on the bones. You may consider a stage surgery where you put your anchors in and wait 3 or 4 months, or put them in and then do halo. All of those are really reasonable. Intra-op, I don't want to exert forces on my anchor points. So doing a temporary rod that goes to the ribs is a great way to get additional correction, using that intra-op halo as well. And then backing up with bands, because actually in these kids, the lamina is going to be your strongest bone. Post-operatively immobilizing them in either a TLSO or a halo, depending upon how proximal you go. You can see here, he actually did correct a fair amount, but especially in that sagittal plane. And you're stretching out all the muscles of your thorax, really helping to address that. And remember, it's the sagittal plane that's my risk factor for anchor failure in this kid. So that's really the most important thing to get corrected because it's going to allow me to put a lot less force on my implants. So intra-op technique for these kids, you're going to want to do at least 6 anchor points proximally. You're probably going to want to add bands to back those up. The bone is brittle, much like what you see in adult deformity. In kids, normally you can expand a pedicle, not in OI and not in Bruch syndrome. So you want to really measure those pedicles, do a line-to-line fill, don't oversize it. Sublaminar bands to back up your construct. I think an O-arm is fantastic for biconcave vertebrae because you can really optimize your fixation, especially if you're going to use cement. I don't use cement in my growing constructs, but I do use it in my fusions. This is this kid here intraoperatively, and you can see, and if I, there, so I did do a temporary rod, and you can see here I'm going to the ribs. So here, sorry, that arrow's in the way. Distal, proximal, this is actually where the anchor points are on the spine, but I went to the ribs in order on the concave side to try to distract them out. This is an example of what those temporary rods look like from Paul Sponseller's article where he described them. So these are what our S2AI screws look like. So I think they look pretty great. You can see here that little horn of bone. I got every last millimeter of it. And you stay just above the notch, which is so critical. It was pretty scary, I got to be honest with you. Using nav for these is really helpful. So if you do have nav available, I would definitely use it if your pelvis is this dysmorphic, because you can see your teardrop view is actually your PA of your pelvis, and that's not a good place to be. So I always say so far so good in these kids. Here he is pre-op, here he is post-op, and I think in particular that sagittal plane looks awesome. He's actually a year out now. We've been lengthening him and he's doing pretty great. But I say so far so good because you never know what's going to walk into your clinic next week.
I think that's awesome. That's great. Michelle, thank you for showing that. Jonathan, I think there were some excellent, excellent questions. But I want to ask one. Somebody sent me a private question, so I'll just ask that right away. But as you talked about bisphosphonates, Michelle, how about kind of medications that we use, in adults like Forteo or Prolia? Do they have?
Yeah, so those are specifically contraindicated in kids. So
okay,
that's
good to know.
Potential. Yeah.
So bone building medications are contraindicated in these kids.
Yeah.
Got it. Okay, so that answers that question.
Other questions?
Dr. Welborn, that was a fantastic presentation. That's a phenomenal post-op image. I'm out of curiosity, how much taller is that patient pre-op and post-op?
Yeah, he gained about 4 centimeters.
Yeah, wow.
Yeah. And so your comments particularly, and so actually I should say 4 centimeters is spine height. And so why is that important? So he was 19 centimeters pre-op. And for those of you guys that are familiar with pulmonary function and scoliosis in our early onset patients, Lori Carroll wrote an article that specifically said 22 centimeters was really kind of that cutoff for severe thoracic insufficiency. So he went from 19 centimeters to 23. And now, so even if he doesn't grow, simply that gain in thoracic height is really going to help improve his future quality of life. Now, she also said she wished she'd never said any specific number because it's really about your proportionality. Like, if I have a 23 centimeter thoracic height in a, Marfan's patient, that's person screwed versus, in like an achondroplastic dwarf where they might be fine. But he had a dramatic increase in his height.
Got you. I'm gonna just read some of the questions that they have here. This is more or less the same question, just asked twice. I'll ask it to you. So, what degree of kyphosis would prevent you from using magnetic rods? And was there any concern about this patient's pre-op hyperkyphosis with a magnetic rod placement?
Yeah. So I think that's a great question because kyphosis is really the area where we have the biggest problems in any growing construct. And what I will tell you is I have used magnetic growing rods in a patient who preoperatively had 140 degrees of kyphosis. So that patient was in traction for about 7 months before surgery, and I got her down to about 90 degrees. So the biggest thing is that contour the crap out of it. And so when you look at these rods, you cannot contour through this straight actuator or for 1 centimeter above or below that. So there are 2 lengths of a magnetic growing rod, a 90 millimeter actuator and a 70 millimeter actuator. The 70 millimeter means 9 centimeters you cannot contour, and the 90 means 11 centimeters you can't contour. So for this kid, you've got to be really thoughtful of that, contour all of that above and below. They often will have kind of a squiggle shape to them because you're going to have, and you can see that a little bit here. I'm not sure if everybody can see because of the, if you minimize the other people in the call, you might be able to see, I killed me. If I go to the very end and I minimize this, you can see here, where's my so far so good? You can see how it kind of gives you this S shape right here. And so I think that's really the way that you can get that to contour around kyphosis. Other questions?
I have one question really quick that was an audience question, but it's my question too. The MRI, somebody asked, is MRI safe for these magnetic rod patients? And I remember a couple years ago, somebody in New York was actually doing the original research on the safety of that with us at USC. And so I know they're safe, but I have never seen one. And so I'm wondering even what they look like. Can you see anything?
Correct. They look terrible. So Selena Poon is the one who wrote that article. And so what we know is that it's safe up to a 1.5 Tesla MRI. Over that, you do get some degree of heating of the rod, which can be concerning. So you don't want to do it in a research MRI, for example. The other thing is that you will get a minimum of 9 centimeters from the point of the magnet that will not be visible. So what you want to do is you want to localize where that magnet is. And if there is, say, a syrinx that needs to be visualized, measure from that to where the syrinx is. And that would be a contraindication. So I have a patient who has an anterior myelomeningocele with an associated syrinx at T2 to T5. I did a traditional growing rod in her because I knew I couldn't get the magnet far enough away to be able to visualize it.
We greatly enjoyed this talk from Dr. Welborn and look forward to seeing you all again next week on Thursday at 5 p.m. Bye-bye.